Hi, my name is Dr. Richard Ursone. I'm an orthopedic surgeon with the San Antonio Orthopedic Group, and I'm going to talk about a new option for limited knee arthritis, which will help maintain activity and function level for patients. Traditionally, when we talk about knee arthritis, what that really means is that the surface of the joint has worn down. So the articular cartilage on the ends of the bones has worn down either from an injury or over time. And so you lose that nice smooth surface. It gets very rough, and which can be very painful and limit your motion and your function. A standard knee replacement that most people have heard about is when the entire knee is affected. So the inside or medial compartment, the lateral compartment, and the kneecap or the patellofemoral compartment all have some level of wear of that cartilage to the point where it's no longer functioning and it needs to be replaced. So this is an example of a total knee replacement where you're cutting the surface off of the femur and the tibia, and you're completely replacing all of the surfaces in the knee joint. So the femur has a cap that goes over the end, the tibia has a tray, and then the plastic liner is the new cartilage. The kneecap's not in this model, but that would also be replaced. So that's a full knee replacement. This is a good surgery when all of the knee is affected. However, that's not always the case, especially in younger patients. Sometimes patients will come in and only one part of the knee is affected, such as the medial compartment here. And in that case, there's the traditional uni-compartment knee, which only replaces that part of the knee. So you're replacing the surface of the femur and the surface of the bone on the tibia. That's a good surgery if both of those are affected, but what do you do if that's not the case? What do you do if only one small area of the bone is affected and you want to preserve your function? So in this model, let's say you have a big divot in the medial femoral condyle here, but the cartilage around it's intact, the meniscus is intact, and the tibia is okay. Do you really want to replace that whole part of the joint, cutting away bone, and which would really limit your function? And so there's a newer technique that allows you to do more of a limited knee replacement called a resurfacing. And so what you do is you kind of drill out the surface that's worn down, and then it's a fairly simple cap that will load onto a little screw that goes into the bone, and the cap will sit flush with the remaining articular cartilage. Let's see. There we go. So you've basically repaired the defect and you've kept the contour of the bone, and you really haven't cut much bone away. It's just one small screw that sits in the middle, and you've been able to preserve the other side of the joint. The benefit of this is that it really allows you to maintain your function. You can run, you can jump, you can do sports. And if in the future, if the rest of the knee eventually does deteriorate, there's little damage that's been done, little bone's been taken away, so you can pretty much have a standard full knee replacement without any complications. And so the two primary areas we're seeing this resurfacing is along the medial femoral condyle, also in the patellofemoral joint. There are a lot of patients who will develop very severe arthritis at a young age that only affects the back of their kneecap here and this groove called the trochlea. The rest of their knee's fine. And so there's not been a great option in the past for those patients. It's very difficult to repair that cartilage because of the motion as the knee bends from a biologic standpoint. And so you can also do a limited resurfacing of that joint where you have a metal cap that will sit in the groove and basically replace the worn out cartilage, and then you can put a plastic button on the back of the kneecap to replace the worn out cartilage on the back of the kneecap, and that way that will be a nice smooth articulation. Again, minimal removal of bone to do that and preserving the maximum knee function. So these surgeries are much less invasive. They can actually be done as an outpatient, and there's no restrictions on your activity afterwards. You don't need to be on crutches. You can walk on it right away, and in my experience so far, most patients have been able to return to athletic events really within 6 weeks, 8 weeks, depending on what their activity level is. So this is a very nice option for the younger patient who has an area of damage to the cartilage that's maybe not severe enough yet to warrant a full knee replacement or a partial knee replacement, but maybe too large of an area that some of the more biologic techniques such as a microfracture or a transfer of cartilage, it's really too big to handle in that manner. So this has been a nice option that's come out recently that's really giving us a good solution to an otherwise difficult problem with good outcomes and good function. Thank you.